This is a talk I initially put together last year. I updated it. Not too much has changed, but updated a few things. It's case-based, so there's about 15 total cases that we will hopefully get through all of the cases. We'll kind of rotate through and let everybody have a chance with one of the cases, and some people may get two. By way of disclaimers, I will say I made this presentation, not the Department of Veterans Affairs. There are some mentioned trade names and commercial products. I am not endorsing them. The federal government isn't endorsing them. They're there just to give you guys information about them. In terms of roadmap of where we're going to go through kind of some ways to categorize or schema in which to a lens through which to view dermatological conditions in HIV patients. We'll go through some cases and then we'll wrap it up with a summary. Why do we care? I love that the stats doctor was talking a minute ago, saying you've got to hit your hook in your introduction, like the key thing when you're doing research is why is this important? And if you can't convince the reader, then you've got to go on to finish your study. Why do you care about HIV in dermatology? Because about 90% of patients living with HIV at one time or another will present with a dermatological complaint related to their HIV. So it's something we'll see commonly if you continue to practice HIV medicine. So you guys are familiar. This is how I feel oftentimes trying to drive in a new area where you're walking around on the honeycomb and it says, face it, Fred, you're lost. And there's a lot of times when things all look the same. It's very clear in a lecture like this, and then when you're looking at the patient in front of you, everything looks like a honeycomb. It's hard to keep it apart. So I think it's helpful to try to get a roadmap ahead of time or a rubric or a lens through which to view things. You guys are familiar with the Vindicate acronym mnemonic there. I will say in terms of things that we're going to see as we go through these 15 cases with HIV dermatological conditions, we will for sure see some infectious conditions. We will see some with a vascular component, and we'll see neoplastic conditions and some autoimmune. Those would be the main places we'll be in terms of this map. Other ways to think about rashes when you're seeing somebody with HIV would be, is this something that is focal? Is it regional? Is it generalized? Is it kind of all over the body? Is it cutaneous or mucosal, or does it have manifestations in other areas? And then is this purely a dermal process, or is this something that's systemic? Is this a dermal manifestation of a systemic disease? So not just with respect to thinking about infectious causes of dermatological conditions in patients with HIV, but in general, approaching a patient de novo, and we're trying to think through, could there be an infection playing a role in the pathology that we're seeing? This is kind of starting from the smallest going up to the biggest in terms of what infections we try to think about, and I think it's helpful to go back to this rubric oftentimes when looking at a patient for the first time and trying to put together a constellation of symptoms. I will not read that to you guys, but you can see what's there. We will not be talking about any prions. We will see some viruses, some bacteria, and we will see some ectoparasites as we go through this. You guys are all familiar with these types of tables that attempt to correlate CD4 counts with different manifestations of HIV disease and opportunistic infections and cancers that can occur. I like this one because that column in the middle that says dermatologic disease, and it gives you a sense of what things you might see dermatologically in different CD4 counts. And you'll note that I think the biggest point is that above 200, you can still see a lot of things. So it's not an easy division that 200 patients are going to be immunocompetent enough to not have some of these other manifestations. And then below 50, it's really just kind of two additional things. These large non-healing HS2 perirectal ulcers and giant mollusca are kind of the things that you can see there. Bacillary angiomatosis stands out as being something that also tends to be seen in people with more immunocompromised. We don't see much bacillary angiomatosis anymore because most of the people in the U.S. are on ARBs and have suppressed viral loads and preserve CD4 counts. Just another rubric looking at it in terms of CD4 counts. and manifestations. And you'll notice over 500 candidal vaginitis is more common in HIV people living with HIV than those not living with HIV. And then you can see Zoster between 200 and 500 pops up as being pretty common, KS as well there. All right, so here is the first case. Who will be brave enough to take this first case for me? All right.
A 49-year-old transgender woman presents to an urgent care with a 72-hour history of fever, sore throat, severe fatigue, and this rash. She engages in receptive oral and anal sites and reports well, mostly anonymous partners in the past 6 months. Most recently, 3 weeks ago, she endorses inconsistent condom use.
Okay, so what do you think? What diagnosis might she have given history?
She may have HIV.
Yes. Yeah, what type?
Acute.
Acute, yeah, acute HIV for sure.
Well, it's syphilis, yeah.
Could be syphilis, yeah, and you can have fleas and ticks. You're allowed to have both. I will tell you, I don't have any combo things here. All right, so Abdullah, what do you? It could be chickenpox for sure. But I'm like you, thinking this is acute HIV. That would be the main thing I would want to rule out based on the time course, kind of her exposure history. Puts it, the most recent was about 3 weeks ago. So in terms of the rash appearing with acute HIV, typically you get a fever first for a few days, and then the rash comes on, usually around 3 or 4 days after the fever starts. So timeline-wise, I was trying to lead you down the acute HIV trail. How about this question, Abdullah? What do you think here?
So from a lab diagnostic standpoint, which of the following results would most strongly suggest this person has acute HIV infection? So I'll start from like the end of the RNA will definitely be positive.
Do you like the RNA being
And
positive?
then
Okay.
the antibody differentiation should be positive. The antigen that will be negative, and then the antigen will be positive.
So which answer do you like best? You're right. There's 3 tabs.
D.
You like D best. Yeah, and I would agree with you. I think you could quibble about B being not a bad option, but if you're asked to pick the one best option, it would be D for sure. I wanted to use this as an opportunity to quickly walk through. As I mentioned, that rash usually comes a few days after the fever. In terms of acute HIV, about 80% of people with acute HIV will present with a rash. They will have a rash in association with their initial presentation. This shows you the timeline in terms of days following HIV acquisition until you get a positive HIV RNA, and you can see there it's within about 15 days confidently. Most people are going to be positive as early as 5 days there in some cases. You can see where the antibody comes in, and then the P24 antigen. And the current test we use, the 4th generation HIV test, is a combination. It's a immunoassay that looks at both the P24 antigen and does an antibody for HIV1 and HIV2. So that is the initial test that is done. The confirmatory test is the HIV1/2 antibody differentiation assay, which you can see here. What the case I gave you there, we had a positive 1/2 antigen antibody test, and then we had negative here, and then you would want the NAT. If the NAT's positive, that would reassure you. Right now at the VA, there's an issue. I think our HIV1/2 differentiation assay, which is also an immunoassay, there's a problem with, I believe, either the instrument or the reagents, and so we don't have that. And so, can you tell somebody based on just the HIV1/2 antigen antibody immunoassay you have HIV, or do you need another test? Yeah, you need another test. That's what the CDC says. You want a second test. So the thing to know is that in most places, what you're going to get then is the 1/2 differentiation assay. You can go right to nucleic acid amplification test, but there's a big caveat. Are all of the commercial assays used for HIV viral load FDA approved for making a diagnosis of HIV? They're not. There's 3 of them that are. So you need to know the place where you work. Is one of the ones that you have one of the approved assays for making a diagnosis? Otherwise, you run into issues where you'd really rather not tell people they have HIV until you know for sure. The combo antigen, the fourth generation test will become positive on average about a week or so before one of the tests, before you would get one of the rapid tests that you can do at home.
How does that make sense? Like, I understand the problem might be approved because they didn't go for the paperwork.
Right.
They have the HIV virus. They have
So it's one of those things clinically you can talk with them and say, hey, this is what this looks like. I guess my point is,
Are you not going to start ART?
I would
Because you
probably,
can't officially give
I would
everyone-
probably lean towards starting ART if I had a compelling reason to do it. But it's important, I think, to know that you have that limitation. Clinically speaking, you're probably going to look at your whatever NAT you have there, but recognize that that in terms of the CDC making a firm diagnosis, only 3 of them that are approved.
And then is the VA
That's
one of
the
those
next
3? Does
Yeah.
TGA
I don't know. You know, I put that in my notes.
Health department.
Yeah.
Can you send him to class and be like, get this?
You could, yeah, you could send a sample to Quest. You're just going to then wait, 7 days to get the answer back. But yes, and I don't know. I told you need to know what assay you have at your place, and I don't. I wrote in my notes should ask what assay we have, and I don't know the answer to that. So, in terms of symptoms with acute HIV, as you can see here, fever is like 96% of people. Adenopathy is common. And you can see down the list there, rash is about 70% of people. So you will see with acute HIV, rash is definitely a prominent player there. All right, who will take case number 2 for me, please?
He presents with complaints of recurrent painful lesions on his penis and scrotum. He appeared about 5 days ago, and he says they aren't getting worse.
So what do you think this is? Yeah, so it's probably HSV. And what do you like here?
This is first infection.
I love that you asked that. So I think I fixed this question so that it, yes, yeah.
So for the first episode, it's usually Valtrex 1 gram for 7 days. But after that, you can do Valtrex 500 to 1 gram. It's like 3 days.
So the options are actually on the screen. Which one do you like? This will be like the board test, unfortunately. You like A. All right. So you like Valtrex, which I agree. I like Valtrex too, but I don't like that frequency. I would go with the acyclovir 3 times a day. And the reason I put this question in here is that for folks living with HIV, the recommendation is not to use any of the short course or once a day treatments. You would go with a more longer course. And there is for an initial presentation, it's 7 to 10 days for an initial outbreak versus for a recurrent outbreak is 5 to 7 days for those living with HIV. That's again, 3 to 5. Yes. So that's it. And you can get away with Valtrex once a day as well. So, but not people living with HIV. It's multiple times a day and higher doses, longer period of time.
Many infections that give HIV longer.
So you can still do Valtrex, but you should do it via.
You could, correct. You could do Valtrex B, but you could do it for 7 to 10 days. I was going to say I would click on that, but it's going to be talented to do the.
Yeah, because it's like extended screen.
Yeah. All right. So who will take this next case?
I can take it.
All right, thanks.
43-year-old transgender woman with HIV, viral load 170 copies, CD4 count 70, presents with complaints of painful ulcerated lesions around her anus that developed about 3 weeks ago. She has taken acyclovir in the past for similar episodes that started about 10 days ago with no improvement. What diagnostics test would you suggest?
What's going on here?
Transgender, low CD4, painful ulcerated lesions. Would potentially could do like monkeypox. We say.
Yeah. So you're thinking Mpox.
Yeah.
You're getting ahead of me in terms of questions. So we're still. Let's. I'm gonna grant you that this is recurrent perirectal HSV. This is HSV 2. And is it getting better or worse than acyclovir?
It's not resistant. Yeah.
So what are we thinking this could be?
Potentially
Resistance.
Yeah, resistance. Yeah. So what test do we order to check for resistance? What's the one test you all know how to do on HSV?
PTR.
We do a PCR, right?
Yeah.
You swab it, you send it for
Yes.
PCR. Is that going to help us here? No. So you could potentially do a genotype, but before that's eventually how they'll do the test. But can they do that right from a swab?
Oh, yeah.
So
Culture.
yeah, we could do viral culture. So this will be like the one time you're going to have to call and figure out, get the viral culture at media. It's actually, I think the media is the same as what we use for the NAT for GC chlamydia. I think it's the viral transport media is the same, but chalk to the lab before you do it. But yes, you're going to swab this. You're going to submit it for viral culture and ask them to do genotyping to figure out if there's resistance. That's coming up. That's coming up. No, I like it. So
So
PL
could
balacyclovir.
theoretically,
I think.
increase the dose to overcome resistance depending on. I've seen that done.
yeah, that's definitely not recommended. So no, we would have to assess those guidelines in the trials to see if they were quality. But in general, there is a time to continue using the acyclovir compounds, but it's not here. It's not in the setting of an acute illness when somebody's getting worse.
Right.
So which medication do you guys like?
Well,
So you guys like IV phoscarnet, and I agree. That would be the right. Now here's the kicker question for you. So you're going to put her on phoscarnet. This is back to your point.
No.
You're not going to put her on suppressive acyclovir.
But this is recurrent. Okay.
It's recurrent and it's resistant.
It's persistent. So
So it's recurrent and resistant. Does anybody want to put her on acyclovir when she finished? Where the phoscarnet, you've got her on phoscarnet, everything heals up. You send her home on acyclovir, or do you not?
that's correct.
I'm,
Maybe. Yeah.
yeah, it is a trick question. You do send her home on acyclovir, and I'll tell you why in a minute. But this, for purposes of understanding where acyclovir resistance comes from, the virus has its own thymidine kinase that takes acyclovir, puts the first phosphate on it. Our own cellular kinases, so mammalian cellular kinases, will then put the other two phosphates on it, which then is a chain terminator for HSV as it's replicated. So that's how acyclovir, valacyclovir work. If you have resistance, the virus never puts that initial phosphate on. Its own thymidine kinase does not function. So you never get the first phosphate, so acyclovir never becomes effective because it can't go further down that trail. Phoscarnet does not require any kind of phosphorylation by the virus, which is why it works, even when acyclovir compounds do not work. From the perspective of sending her home on acyclovir, you can almost think about this kind of like with HIV, where you have, you can think of a swarm of viruses with different types of genotypes and different types of resistance. They get archived over time. Even when you have an outbreak of HSV related to or due to an acyclovir resistant strain, subsequent outbreaks may be due to an acyclovir susceptible strain. And the recommendation, anytime you've gone to the trouble of treating somebody with IV phoscarnet to get rid of their HSV, you send them home on acyclovir because it's been proven to decrease the risk of recurrent outbreaks, even though it's nonsensical because you would say it shouldn't work because it's resistant. I hear myself talking back to me.
That's probably on the computers.
Oh, on this one.
I think it's gone.
Okay. All right. I thought I heard it from back there. It's not on. All right.
And now it's not.
So yeah, nonsensical, but that is the recommendation to send them home on acyclovir. One of those times when you do something that doesn't necessarily make sense, but when you think about the fact that some of the virus that is hiding out in the nerve ganglia will retain susceptibility to acyclovir, you get some benefit from it. And the fact is it works. It decreases out recurrent outbreaks. What's that? Yeah, it's one of the few times when you go, because right, you would expect like in HIV, you would never treat with a single drug because predictably, like with zidovudine in the early days, 6 months after you started, the virus is resistant. In this case, treating with a drug that you wouldn't predict would work actually has a clinical benefit. All right, we'll grab this one for me.
33-year-old cisgender woman with HIV viral load less than 20 and CD4 count 320 presents with this painful rash on her left leg that started 3 days ago. On physical exam, she has a vesicular rash and a dermatomal distribution of the left leg. She has no systemic symptoms. I'm concerned that could be Zoster.
Yeah, sounds like Zoster, right? So
Unilateral distribution.
yeah, I would agree. This seems like Zoster. Do you think people with HIV have the same risk of Zoster or decreased risk? Higher. And it's interesting, over the last 20 years, as people have gotten more on ART, the increased incidence of Zoster in the HIV population has decreased, but is still slightly more likely, and it's definitely more likely the lower the CD4 count goes. All right, so before I go to the next slide, because this will be important to frame the question, does she look like her HIV disease is well controlled, not well controlled, and how immunocompromised do you think she is?
She looks well controlled, undetectable.
Yeah.
She's young, so her CD4 count could hopefully go up a little more with some more years. But and I think the distribution of the rash being not systemic or disseminated would hopefully indicate too, if we didn't have the numbers.
Yeah. No, true. You might expect that if her CD4 count was, less than 200 or less than 50, that she'd have disseminated disease or more severe disease, for sure. All right. So, which of these things would you recommend for her?
I probably would give her orally cyclovir and prednisone for 7 to 10 days.
That's what you like. And I think we're used to that, especially coming right out of internal medicine residency. Like, that's what you do when you see something with Zoster. The trick here is that in the case of patients living with HIV, the recommendation is not to use prednisone. Hasn't been studied. There's concern that you might end up causing worsening of the disease. So the recommendations that are out there are just use the acyclovir compound. The other thing is you get a longer window. What number do you guys think in your head? Immunocompetent HIV negative person, how many days after Zoster onset would you start valacyclovir or acyclovir?
So as soon as they have diagnosis done.
Yeah, but let's say I come in and tell you, hey, this rash that's all crusted started 10 days ago.
Oh, no.
Yeah. How many hours after my rash starts that I show up in your clinic would you say, I'll give you some valacyclovir? 72 hours is the usual cutoff. Honestly, clinically, kind of to your point, am I going to not start ART in that? If they're there and there's new lesions popping up, everything's not crusted, it's reasonable to treat. HIV, though, what you'll see written in recommendations is out to 7 days. So whereas we give the average Joe who shows up 72 hours, we would give somebody living with HIV 7 days. And in reality, you're going to start it in most people who have new lesions forming or incomplete crusting.
Yeah, I've never heard of that.
It's recommended to it decreases symptoms, is the bottom line. It helps with symptoms. Yeah. I have to look at the caveats for when it's specifically indicated, but that's still pretty commonly done.
I would expect the valacyclovir gabapentin or something.
That is, there's data for that to an NSAID. So that's the recommendation for people living with HIV, that you would go to NSAIDs instead of using prednisone.
Does it have any effect on the risk of post-herpetic neuralgia?
I want to say that's been studied, and I think there's studies pointing both ways in terms of whether in HIV negative population, if giving prednisone along with the acyclovir compound decreases the risk of post-herpetic neuralgia. I think some studies have said yes, some have said no. Are we treating ourselves or the patient when we give prednisone? I don't know, but it's in the recommendations that you can think about doing that. So. But not for people with HIV. Don't do it for them. So here's the bonus question that you get, because you're the Occ Health guy for the day. So tell me what you think of this one.
Patient is a nurse in an outpatient family medicine clinic. What would you recommend from an occupational health perspective? I mean, I would not cover the lesions, but maybe I probably should because it's transmitted that way.
That's the least restrictive thing.
Mhm.
You can cover it. You
Oh,
can cover and
patients
restrict
that are-
from high risk.
Okay. Let's say D.
Yeah.
You guys like D?
We don't. It's a strem.
Well, now this is one where, thankfully, the CDC has published some guidance on this for us. So if you go to the Advisory Committee on Immunization Practices, Work Restrictions for Healthcare Personnel, Table 5 and the guidelines here, and I've got the link down there. This table is super helpful. If whatever hospital you end up at, if you end up being tagged to do some OC health, do some infection control, infection prevention stuff, this document and this table is super helpful in terms of what kind of work restrictions for what conditions. You look up the disease condition, it tells you what to do. So in this case, I asked you to look at her a little bit critically a minute ago about whether she's immunocompromised or not. We'll get back to that question. I'm going to start with column 2. You have 2 work restriction levels. You can cover lesions, restrict from care of high-risk patients, or you can exclude from duty. So what is a high-risk patient? So that's what a high-risk patient is, those susceptible to varicella, increased risk for complications. So neonates, pregnant women, immunocompromised persons. So family medicine clinic, do you think there's high-risk patients there? Yeah, I think there's high-risk patients there. The other question, so that question I think becomes automatically, you're going to restrict her from the care of high-risk patients, which is going to probably mean you're not working in a family medicine clinic because there's high. Where could she work? I'm left going, where could you work? Like an internal medicine clinic that only has healthy 45 to 65-year-old people? I don't know. But at any rate, from the immunocompromised perspective, figuring out who's the immunocompromised employee, because that's the question, is she immunocompromised? So we think her risk of transmitting it is higher. Believe it or not, the guidelines steer you to the COVID-19 vaccine and disease precautions in terms of who do you consider immunocompromised there. It's like this circular logic that brings you all the way back around. What I found, everything on the federal government websites now, when they're defining what moderate and severe immunocompromising conditions are, steers back to the COVID-19 website. And so you can see here, does advanced HIV count? Yes, but that means CD4 count less than 200. History of AIDS defining illness without immune reconstitution or clinical manifestations of symptomatic HIV. Is that her? No, she didn't have that. So in her case, the driving factor, when you go back to our table, the driving factor here is the fact that it's high-risk patients, and for that reason, you're going to restrict her from duty.
So you're just going to restrict her from
Well, I think the whole clinic is too high risk because what is she going to do? Like,
it's not really your,
you could.
It's not your determination.
True. And you're not the OC health doc. What I'm saying is sometimes you may get asked by the OC health doc to participate, and sometimes you can negotiate extra pay to participate in that kind of decision making. You can get a 0.1 FTE from a hospital system to be part of their OC health committee that makes these kind of decisions. Yeah. Yeah. Have you? Like, I don't know how you'd rule that out. It would depend how many days have gone by. You'd really want to do a good skin exam, see if any more lesions are popping up anywhere.
Questions.
Yeah. True. True.
In the question.
Well, I guess it's how lucky do you feel? Because that's the flip side, right? You put her back in circulation, and then you get a case of transmission to a pregnant woman who never was vaccinated as a child. Now the downside, these discussions get outside of the realm of ID and more into OC health and more into like HR. But there's repercussions either way you go. If you tell her you can't work, now she's not getting paid, she's out of work, that's a problem. You put her in with patients who notice that she's in pain and her flank is covered for some reason and they're not sure what's going on there. And then you have a nosocomial transmission to a patient and you got problems. So they're tough situations that are beyond the scope of what we're going to answer in this 1 hour. All right, who wants to grab this one?
23-year-old cisgender man with no past medical history, seen in clinic for evaluation of a rash on the cheek and forehead. He does not have any systemic symptoms.
So what do you think? What does that look like, Mr. Death? Molluscum, yeah. And on what part of the body?
Face.
Yeah. And is it like one lesion or
Many.
lots? So what are you concerned might be going on here? HIV? Yeah, correct. Because is molluscum common in the US or not common?
Not.
It's common to have one or two lesions in a kid. Is it common to have an adult with all these lesions on their face? No. So, and HIV is by far the leading predisposing factor that's going to lead you to that kind of presentation of molluscum. So his HIV antibody antigen test is positive. Differentiation assay shows HIV-1. He's got a CD4 count of 93 and a viral load that's 178,000. But what do you like treating this man's skin lesions? Yes, correct. Yep. Molluscum will get better in general with antiretrovirals. You can see an iris phenomenon with molluscum that when you start people on antiretrovirals, they may actually get worsening of the molluscum, in which case topical treatments are what you would use. There's not really a good systemic treatment for molluscum. All right, just to grab this case.
39-year-old and sex with man with HLPA on retroviral therapy with recent CD4 765 undetected larvae presents with a rash that's very painful. It started 10 days after engaging condomless or separately having sex with a partner of a party in New York. The rash began perianal but spread to multiple parts. He's also on infliximab and D. Comes to the ED because new lesions continue to appear with the pain is intractable. He has had to stop eating, drinking, and all business.
So here are the lesions. Yeah. Looks like Mpox. Yes. So we're gonna grant you that your PCR came back positive. What'd you do for this guy?
I thought the data showed that Mpox doesn't.
Yeah. So I almost changed this question last night, and I left it. And I'm glad that you guys are jumping on the fact that in taking a test, you got to pick the one best answer. So I think I heard you guys say your one best answer for this would be tecovirimat, given what you got. This guy, I painted him as being immunocompetent, I think.
Yeah.
I think
control.
765 undetectable viral. So I think that is probably still, if you were to poll the eminent people, the subject matter experts who make these recommendations, I think for that patient, this would still be the recommendation. Those trials that you're talking about that came out, the randomized control trials, really showed that tecovirimat did not reduce the risk of, didn't reduce the duration of symptoms. It didn't have any effect on mortality. Mortality was low in the Mpox outbreak since 2022, in which this was studied. So compared to historical mortality, the rates were low across the both arms of the randomized controlled trials. But you're correct; it didn't reduce symptom duration, didn't reduce number of lesions that form. In this case, with a guy who's still pretty immunocompetent, treatment with a single drug would be reasonable. If I painted the guy to have a CD4 count less than 200, I think what the recommendations would be now is to treat with 2 of these drugs. What do you think the second drug is?
D.
Brincidofovir.
Oh,
yeah, would be the recommendation. That has got an FDA indication for smallpox, not for Mpox. So to get both of those drugs, both the tecovirimat and the brincidofovir, is going to be going through an EUA process or the protocol type process. So it's a challenge to get either one of those. What do we have on the shelf that we could use? Cidofovir. That's like we've been using that for decades. So you could get cidofovir easily, and you could get the tecovirimat and brincidofovir with some effort. The intravenous vaccine, likewise, is only available through the federal government, through the strategic national stockpile. Nice table from JAMA that basically goes through the agents that we have there. Tecovirimat can be oral or IV. So when somebody who can't take oral, you'll notice most of the like brincidofovir is oral. If you have somebody who can't take oral, the tecovirimat is an option between those two. So yes, I think for this patient, would you want to treat him because things are getting worse? Yes, we want to treat him. do we have good data saying that in all comers, those RCTs, to be fair, were competent patients. It wasn't just confined to HIV patients. Yeah.
Suppress it enough.
To give them a second drug. I think I will say right now, and I almost made it, like I said, the 2 drugs last night. I think that you could argue it either way. I think you could argue just doing tecovirimat. I think you could argue.
But it's more like that, how much the HIV is controlled in this case.
Correct. Or like somebody who's a bone marrow transplant patient, somebody, if you have some other immunocompromising condition, but you're right. I think the infliximab combined with the HIV or CD4 count, it would be fair to go right to 2 drugs. But you're looking for, if you got a choice on a test, you're looking either for tecovirimat monotherapy or tecovirimat here would be the number 2 option.
Are there any scenarios where you'd use immunoglobulin?
Quick way to know. Thank you.
Are there any
Scenarios where you use the immunoglobulin?
where you do
Use the immunoglobulin.
So yes, mostly that's if you have a contraindication. If you had like the patient had a problem, already had liver damage, already had maybe diarrhea and they couldn't absorb the pill, you might go with the immunoglobulin. So immunoglobulin is like, there's some data for it, and it's pretty much the third line. I would say tecovirimat is number 1, brincidofovir, and then the vaccinia immune globulin. Tecovirimat, the issue is resistance has emerged. It's pretty simple mutation for the virus for Mpox to become resistant. And so we're definitely seeing resistant cases or resistant strains of Mpox. In particular, people who were on tecovirimat for a long time, people who were severely immunocompromised, had a long oral course of it, then developed viruses with resistance. Yeah.
Would you mind like commenting on the trifluoride for like the eyes?
Yeah.
How would the Mpox be like on the eyelids, or the actually?
Correct. So it'd be keratitis. It would be if you had Mpox in the eye. So if you had an ocular infection with Mpox, that's the time that is helpful. The only time, it's not for systemic. For our guy who had no ocular involvement, that wouldn't be something you would use. For somebody who has ocular involvement, that would be the time that would be useful. Yeah. Yeah.
5 people with Mpox, 2 of them have worsening or treatment. Sent out the samples to CDC to tested them, but tell us if it was resistant or not, but they knew because it was validated assay. Getting the print side of the work wasn't as difficult. It still required a couple of calls, but both of them tolerated it well, improved clinically, didn't have much side effects.
Yeah. No, that's good. So I treated exactly 1 case, and it was with tecovirimat, and she improved. But it's, I think the data we have would say use both. If I had a severe case, that's what I would try to do, is use both. And you can't get them. It's just, it felt like doing a drug deal in San Antonio because the tecovirimat came from the county public health department, and I literally met the lady like in the parking garage and got a bag and took it in, handed it to the pharmacist who accessioned it, and then dispensed it to the patient. So you got to figure out wherever you're working what the process is of how you're going to get the drug. Yeah. All right.
Is there a second person with them?
Shiloh, we're up on the hour. I'm happy to keep going or to stop if we need to stop. Okay.
Yeah, I have a great thought.
All right. So we'll go through these cases quick. Who wants to grab this one? And we're graduating from viruses into the next higher order organisms here.
21-year-old cisgender man with HIV is in clinic for evaluation of this painful lesion. He's had 2 similar episodes within the past year, and cisgender trainers with the absence of performed what pathogen do you anticipate will be isolated sculpture? So looks like vascular dermatosis.
That's coming up. That is coming up. But let's think what's common things are common. What's the most common skin? Oh, staph and MRSA. Yeah. So, and correct. And what do you think, MRSA is more common or less common in people with HIV?
About the same.
A little bit higher incidence, a little bit higher carriage rate in most studies, a little bit higher carriage rate. What about recurrence of MRSA? Is that more common or the same? A little more common. Yeah. I think. All right. Here's the question.
Which of the following is true regarding community-acquired MRSA, skin and soft tissue infections in a person with HIV? I feel like it sounds correct.
B is out.
Yeah, I think I already gave you guys B. That's a good short term.
Yeah.
So B
Hey.
is out.
Hey, you guys like it. I agree with you. And so all those other things, therefore, not true. Okay, this is the case you were looking for. So who's going to grab this case?
A 54-year-old cisgender man with HIV and a CD4 count of 66 presents to the clinic for evaluation of several of these painless purpulate nodules on his right arm. He cares for multiple stray cats. He is not taking any medication. He has no systemic symptoms and exam is otherwise normal. What diagnostic test would you recommend? That does look like bacillary angiomatosis, and is it a Werthen-Starry thing?
So what would you do the Werthen-Starry thing?
Biopsy.
Yeah.
Biopsy.
Yeah.
Cut it out. Yeah, take a biopsy and you would do a diagnosis based on the pathology, which I agree. And the word that I'm trying not to be as pejorative as my instructors were when I was in your situation, but they used to call it the worthless starry stain. Many times you do it, and very few times does it actually show the organism. So it is the Werthen-Starry stain, but sometimes it's worthless. But you do it. That's correct. What other tests could you do in this guy?
PCR.
You do PCR. So you can do PCR on a biopsy or on the blood, or you could do what with the blood? You can do an antibody. You can do serology. Can you grow it from the blood? What's the organism?
Yeah, you can, but it's difficult. It requires long implementations.
Yes.
And specialized
You
media.
got to hold it for a long time.
Yeah.
It'll grow.
21
In
days.
The average Bactec bottles nowadays, it will grow, but you got to hold it longer. So you have to talk to the microbiology lab and say, hey, look, I know you want to get rid of that bottle in 5 days, but I really want you to hold it for 20 or longer. And and usually they'll deal with you. What are the 2 species of bacteria that can cause this?
Bartonella Hensley.
Hensley, and what exposure does he have that
Cats.
goes with Hensley? Cats.
Yeah.
So from fleas or from the cats themselves.
Yeah.
And then what's the other species?
Quintana.
And what's the association there? Where does that come from?
Fleas.
Uh,
I'm sorry, not fleas.
so body lice.
Lice. That's ones.
All right. So here is the here's the question. How do you guys want to treat this thing?
It's just for cat scratch.
So you're saying A is
No, that's just for just simple cat scratch.
correct. That is it. So I'll tell you, A, B, and C are all right for something, but they're not right for this. So D, correct. Go long. When in doubt with a severely immunocompromised person with bacillary angiomatosis, go long. Number 1 or A is the correct answer for immunocompetent person with cat scratch disease. B is going to be hepatic disease.
C is retinitis, right?
And C is going to be retinitis.
Yes.
Correct. Yep. Neurologic or retinitis. All right. We'll take this one for me.
Ooh,
That's as bad as me saying worthless starry. We have to say crusted scabies now. We're not allowed to say Norwegian scabies. So
Mr. Norwegian.
who's going to take this question for me?
26-year-old cisgender. Obviously have very good skin very itchy at first, but it doesn't itch anymore. On exam, you notice it's crusted, it's fissures, it's very smelly. It's notable for it's absolutely eosinophil count of 1,500. What diagnostic test would you pursue? You need to scrape it and look at it.
That's great. Yeah. So you can do a scrape, or you can do or if you're a dermatologist, you can do dermoscopy. I don't know. We got to get an IDoscopy. I'm like, we got anoscopy that the colorectal surgeons do, dermoscopy. I don't know what our microscope that we push on the patient would do. Yeah, we'd have to get it. It has to be at the bedside though. So top 2 are scrapings showing the scabies, and then The bottom is what dermoscopy would look like with that triangular shaped form being one of the scabies organisms. And then what would you do for this person?
Oral resectomy.
Yeah. Yeah. It's horrible. And if you want to be really frustrated, look at the recommendations on ivermectin. The dosing, like it literally in the guidelines says, give this on non-consecutive days. And I'm going, how about, like, it's literally a regimen that's like day 1, day 8, day 9, day 15, day 21. It's bizarre. It makes the rest of us look like our 7 and 10 make sense. But yes, you're going to do both for this person. And the issue is the burden of organisms encrusted scabies is high. You're talking millions of organisms versus in a standard case of scabies in an immunocompetent person, there may be 10 or 15 organisms on the whole body. Here you've got millions of organisms. So it's going to take a long time to debulk the infection.
Do you get people to debulk?
Does it resolve? It gets better, but in terms of like, do you take a
should wound care
iron? No, you don't do that. Don't do that. No, in terms of, it's just supportive care for the skin. It's just supportive care. It's not, there's no kind of debulking or. It'll, well, those if you biopsy those organisms, each like cubic, millimeter is going to be packed with organisms. So you'll slowly work your way down. Yes. You're
talking from inside.
Correct. Yeah.
It's not dead skin, it's the
correct. Yeah. It's a slow boat. All right. So
Norway wants to be known for the Nobel Prize.
Not for
I mean, it was discovered in Norway.
So
That's how it got the name?
Yeah.
So there's three things. You're back to where you're on health.
That's not good.
Yeah.
Oh, yeah.
I think there was stuff inpatient getting it.
Yeah.
They can do, they'll do their dialysis in a private room. Yeah. And so, again, this is like worst Friday afternoons. Being an ID doc is where you get a call like this from your dialysis center, which like the DA. But yes, there are indeed, there's not post-exposure prophylaxis. There are these guidelines that tell you what to do in terms of your long-term care facility and different strategies for when you have patients who pose an infectious threat like this. So, all right. So we'll take this question.
What would you picture in my head?
Yes, let's have a nice disclosure.
HIV returns clinic after 1 year absence. It's not been taking its ART the last 9 months. His CD4 count is 210. Examination notes several non-tender purple non-mutations on the upper arm chest area. They've been growing slowly for 2 to 3 months. He has no systemic symptoms or edema. What diagnostic test would you do?
That looks like KS.
Biopsy. Kaposi?
Yeah, it looks like a Kaposi sarcoma, right? So yes, so you could do biopsy with the appropriate thing to do here to make the diagnosis.
In most cases, do you need to do like the whole like excisional, or can you do a punch, or like?
You could just you could just do a small biopsy. Yeah, you don't need to do a wide excision or anything like that.
Because you know some cancers you have to take the whole thing out, or you're receiving it. Is that? So
no, that's not a problem. What's the underlying cause of Kaposi sarcoma? What's the infectious?
HHV8.
HHV8, yes. And so, so there is an infectious cause underlying it. So, Aaron, what do you want to treat this guy with?
I think it's I don't think you're going to do chemotherapy unless it's like really broadly disseminated.
Correct.
Yes.
Correct. So this is, again, me trying to trick you guys. This is a perfectly cherry-picked case where I think I told you the chest x-ray was normal. The guy had no symptoms. So antiretroviral therapy alone. If somebody has
pulmonary
organic GI or pulmonary or widespread disease, then you would have had chemotherapy with it. What about IV cytopheresin? Is that going to help? Will that help you out?
No.
No. The issue with the HHV8 that is associated with Kaposi sarcoma is that it's mostly in a late phase. So only 5% of the virus in this situation is in the lytic phase where it's actively turning out copies of itself, which is where the cytopheresis would work. And so it's not going to, treating Kaposi sarcoma with an antiviral like that is not going to get you anywhere.
What about for primary fusion lymphoma? Is the treatment different?
I don't know. I don't know the answer to that one. Yeah, we'll have to look that up. As with many of these things, I would recommend when you encounter it, look it up. But
Yeah,
this is good for association, but I don't know the answer to that exact question. All right, so
R-CHOP?
So skin cancer, just some pearls, basal cell carcinoma, 2-fold increase in people living with HIV. Squamous cell carcinoma, 2 to 5-fold increased risk. Melanoma, 2 to 3-fold increased risk. HPV, genital in situ, and invasive squamous cell carcinoma of the genitals, both increased in patients living with HIV. All right, we're in the home stretch. We're transitioning from cancer to
44-year-old male, HIV CD4 count 175, viral type 1, sulfa, CG, growth B presents fevers without direct contact, face nebula, had with rash. I've been switched from to RV, $2 a compare. Like the aggressive CKB.
So what is this guy got?
B?
No, hypersensitivity reaction.
Yeah, to a back.
To the back.
To back of yeah.
Hypersensitivity. And the key thing here is I'm giving you a rash, but more importantly, you're getting
The timing.
this sort of the dry cough in the time. Yes. So back of your, why have you guys ever seen the back of your hypersensitivity? Yeah, I saw it a couple times before we had HLA-701 testing, but yeah, it was bad.
Yeah, when they died.
Yeah, correct. So you don't ever re-challenge. You don't ever, if somebody comes in like this, ever say, well, maybe we could try putting the back of your back over. So what's the next best step for this guy?
See, stop it first, and then test.
And then test. That's exactly right. All right. In terms of where is HLA-B5701 most common, it's in the U.S. It's going to be in white people, and it's common in Europe. Okay, in that area. There's also there's a lot of variability, but India like 5 to 20%. I'm like, I think we need some data.
Yeah, that's a wide range.
It's a pretty wide range. But pretty much, as far as pharmacogenetic testing goes, the HLA-B5701 was one of the first tests that made it to market that we used to help us decide whether or not to use a drug. And the bottom line is, anybody entering into care with HIV where you're thinking about using a back of your, that test should be done. For the sake of time, I'm gonna these are just highlighting for you, if you want to flip through the slides later, which of the ARVs are associated with SJS and 10 and DRESS and those kind of things. And it's not, most of the ones we use today are not. You may find a case report trying to say that dolutegravir caused a really severe bad TEN or something like that, but they're rare. Some of the older drugs we use, particularly nevirapine, is one of the worst offenders. This was a much more common problem. All right. You guys think about this one.
A 48-year-old cisgender man with HIV presented painful per day, generalized erythema, scaling. He has not been engaged in medical care for the past years, not taking meds. He says he has had a rash intermittently for many years. Psoriasis.
So this is bad psoriasis.
Yeah, gotcha.
C.
No, I think
B? Yeah.
Yeah, I like B. So yeah, in people living with HIV, generally psoriasis is more severe. You can treat them if they need to go on immune modulating meds and their HIV is under good control. They can, obviously, but psoriasis can be a lot harder to control in people living with HIV. All right.
44-year-old cisgender man with HIV 4 months ago. Diagnosed with HIV 4 months ago. Initial CD4 39, viral load 123K. Started on antiretroviral returns and follow-up. Exam revealed a diffuse rash that consists of pruritic erythematous papules associated with hair follicles on his neck, chest, back, and upper arms, spares the axilla, hands, feet. This rash has worsened in the past 3 weeks. Otherwise, he feels well. HIV RNA is now less than 40, and CD4 count is 227. Skin biopsy shows parafollicular infiltrates of lymphocytes and eosinophils. The is the most likely answer.
See.
C.
Eosinophilitis, yes. This is common in patients living with HIV, especially with low CD4 counts. It's something that you can see commonly. All right, I think this is the last picture we got.
42-year-old cisgender man with HIV and a CD4 count of 54 is seen in the clinic for a follow-up visit. He recently started taking ART. His physical examination reveals scaly erythematous plaques on the scalp, face, and beard region that look like seborrheic dermatitis.
Yes. Yeah, subderm. That's it. So, yeah. What's the fungal species that the antigen that causes this type of reaction?
Yeah,
Malassezia.
Malassezia?
Yes, Malassezia. That's it. All right, and this one, I just wanted to comment quickly. This is deeper than the skin, but what am I showing you on the left there?
The lipoatrophy.
Lipoatrophy. What are the ARBs that cause lipoatrophy?
The protease inhibitor.
Mm-hmm. No, it's two. We don't use them anymore. So it's adavudine, or I'm sorry, yeah, D4T and Savidine, and I want to say I think it was adavudine as well. I think those are the two that are most associated with it. None that we use today. None of the ones we use today are associated with lipoatrophy. Lipohypertrophy, on the other hand, so weight accumulation. Do any of the ARBs we use today are associated with weight accumulation?
Yeah, so the increase inhibitors.
Yeah, all of them are. It seems like all of them are. Perhaps efavirenz has a protective effect, but for the most part, lipohypertrophy is the main problem we see now, and it's kind of with all the different ARBs that we use. I think that's it. Last minute, there's some CD4 count associations for folks who like that, and that's it. Questions from you guys? Were a great audience, by the way. That was appreciate your participation and good questions. Thank you.
Thank you.